preventing the risk of foot ulceration by regular nail trimming and scaling of the nails. Next, look at the crooked nail. This nail has grown, overgrown, has become so thick and is almost piercing the second toe. You can imagine what will happen to this toe if this nail continues to grow like this. So if we trim the nail and put a spacer in between the two toes, we can prevent the injury to the neighboring toes. Next. This is the garden variety of neuropathic plantar ulcer, which usually develops on the heads of metatarsal and is surrounded by a thick callus and has a red granulation tissues. Next. The second way the feet get affected is loss or decreased blood supply because of obstruction in the blood vessels, as you can see. Next. And the ulcers that occur because of ischemia are little different than what we saw in neuropathy. Here the ulcers occur on the margins of the toes. They are necrotic, not surrounded by callus, and are usually painful. Next. So come back to the original slide. We have two basic problems: neuropathic feet, where neuropathy is dominant; neuroischemic feet, where ischemia due to reduced blood flow is dominant factor. Next. And differentiating between these neuropathic and neuroischemic feet is extremely important, as complications, prognosis, outcome and treatment modalities are altogether different, and therefore we should be able to identify which feet are neuropathic and which feet are neuroischemic. Next. And this can be done by simple testing at the bedside of the patient. This is testing for the sensory loss or loss of protective sensation using a monofilament. This is a 10-gram monofilament which is applied to plantar aspects on the first, third and the fifth metatarsal head or on the ball of the great toe, and when you apply that monofilament and allows it to buckle, patient should be able to appreciate that buckling. If 2 out of 3 answers are incorrect, you can almost certify that patient has loss of protective sensation. Next. Or we can also assess the sensory system using biothesiometer, where the vibration sense is measured and it can be quantified during with the machine, and you can almost measure at what level the vibrations sense appears and at what level or voltage it disappears. Patients with neuropathy have no appreciation of vibration strength, and their VPT is beyond 25 volts. Next. The peripheral vascular disease can be examined simply using the hands, and we should feel for peripheral pulsations. This is dorsalis pedis, and we can also feel posterior tibial at the back of medial malleolus. Next. We can also examine the feet to decide ischemia. You can see that the feet are dusky red, there are no hair on the dorsum, and the nails are dystrophic. And if you raise the foot and bring it down, it becomes red. This is a sign of peripheral vascular disease and is also referred as dependent rubor. Next. This peripheral vascular disease can be quantified using handheld Doppler, as you can see, and measure systolic pressure. Normally, the systolic pressure in the upper limb is more, the ankle pressure in the lower limb is more than the upper limb, and therefore the ratio of ankle to brachial pressure index is always more than 1. But in presence of peripheral vascular disease affecting the lower limb, the ratio is reversed and you get ankle brachial pressure index less than 0.9. Next. And this is how the neuropathic and neuroischemic ulcer can be differentiated, as I have already explained you earlier. Next. 85% of the amputations are preceded by trivial ulcer, And therefore, if we recognize early foot ulcerations or early signs of damage and aggressively treat them, we can reduce or contribute greatly to reducing leg amputation in our diabetics. Next. So these are the trivial looking foot lesions, blisters, interdigital mycosis or fungal infection, abrasions because of the footwear injuries or nail pathologies. If our paramedical staff is properly trained to handle such trivial foot lesions, they can contribute to great extent in reducing leg amputations in diabetics. Next. And in our clinic, patients should be screened for high-risk feet, and if we have, this is how the risk categorization is carried out, grade 0 where there are no loss of protective sensation, and these patients should be followed up annually, but patients who have loss of protective sensation plus deformities should be followed every 6 months. Those who have peripheral vascular disease and loss of protective sensation, they should be followed more frequently every 2 to 3 months, and those who have had ulcer or amputation in the past should be followed every 1 or 2 months. Next. The characteristic of preventive footwear are, we should always advise about the footwear to all our patients with diabetic foot problem, because these are protective footwear and they should have broad toe box, soft insole, rigid outsole, extra depth, and the lining should be non-traumatic. Next. And this is an example of preventive footwear where you have a back support, soft insole, broad toe box and other features. Next. Or footwear, you can again see the broad toe box, rigid outsole, back support and non-traumatic lining. Next. This is the footwear which we should always categorize to our patients, that they should not be wearing Hawaiian slippers or for that matter chappals. They should always wear sandals or boots. Next. Instructions for patients should be, new footwear should not be worn for longer time. Buy footwear in the evening when there is a little swelling over the feet. Check shoes for foreign objects. Footwear and insoles should be periodically checked. Examine the feet for reddened areas, and footwear should be called as effective. It prevents the buildup of callus recurrently. Next. And for patients, we should always educate their patients what do's and don'ts they have to observe. Next. For example, they should regularly wash their feet, especially wash the feet in between the toes. Next. See the plantar aspect of the feet. Inspect every day in the evening for any injury or red areas. Next. Apply creams or Vaseline on the dry feet so that they don't crack or develop fissures. But they should not be applied in between the toes. Next. Nails should be cut regularly, cut straight and not very deep. Next. They should always be wearing cotton socks, preferably white socks, and the elastic at the upper should not be very tight so as to stop the blood supply going to feet. Next. And they should always inspect the footwear for any foreign objects before wearing it. Next. And never walk barefoot. Next. And these are the don'ts, like, next. They should not walk barefoot or else they will traumatize their feet. Next. They should always check with the temperature of the water during bath or wherever they are using any hot water bottle or any such surface or sitting near the fire. They should see that the temperature is not too hot or prevent their feet from thermal injuries. Next. They should always see to it that the socks do not have tight elastic. Next. Should never carry out home surgery using such unsterile sharp objects. Next. And should not be wearing such chappals or go barefoot on motorbike. They should quit smoking, especially if they have diabetes and feet disorder. And these are the warning signals. Next, if they feel that their feet are smelling, or next, if their feet are hot, or next, if their feet have ulcer or pus discharge, next, or any such reddened areas, next, they should immediately report to doctor. And all patients should be educated, especially those who have diabetes with loss of protective sensation, that their feet are important and they should love their feet, and even feet require rest. Thank you. We'll see the examination of the feet. For examination of the feet, we have to remember two important: inspection and palpation. And to be frank with you, for examination of feet in diabetics, we don't need very sophisticated instrument. What you really need is pair of sensible hands and eyes. While inspecting the feet, we should look at the texture of the skin, we should look at the hair present on the medial aspect. These hair are lost when there is a reduced blood supply. We should look for any areas of ulcerations, redness. We should also look at the nails, the texture of the nails. The nails should be transparent, but in diabetics you can find them totally opaque and deformed and scaly and discolored. We should also look for any bunions on the dorsum of the toes. Then we should inspect between the toes for any fungal infection. Then the important aspect is the plantar aspect, because this is the area which gets ulcerated in presence of neuropathy. So we should look for any evidence of cracks or fissures. These are the metatarsal heads. They become abnormally prominent in diabetics. So we should look for any such prominences. We should look for calluses underneath these prominences and look at the toe tips. Then we should also look at the peripheral pulsations. Usually they are on the lateral aspect of this tendon, extensor hallucis tendon. This is the tendon. Peripheral pulsations. This is where the dorsalis pedis should be felt, lateral to this tendon, extensor hallucis tendon. And posterior tibial can be felt behind the medial malleolus to detect the peripheral vascular disease. And of course, we should always look for any other abnormality or change in the shape of the feet. The heels should be examined, because if the patients have neuropathy and are lying in bed for some other disease, they tend to develop heel ulcers or necrosis underneath the heel, and that's very difficult condition to treat, and therefore heels should be inspected. After that, we should do examination further to detect whether patient has loss of protective sensations. For detecting this loss of protective sensation, these 10-gram monofilaments are used. This is very simple monofilament for testing of sensory system, and usually we apply this on the heads of the metatarsals. When we apply this monofilament and allow it to buckle, patient should be able to appreciate that buckling, that pressure, not the pain, the pressure of buckling. And he should be asked to say yes or show the finger or some sign so that he is appreciating. And then you switch over to next side. For example, I will ask, if you feel, you say yes loudly.
Yes. Yes. Yes.
So at 3 sites I tested and all the answers were correct. If you find 2 answers incorrect, you can almost quantify that this patient has loss of protective sensation. They can be also tested on the ball of the great toe, on the dorsum and heel and other area. But these are the common sites. Then this is a 128 Hz for testing vibration sense, tuning fork for testing vibration sense. And for testing vibration sense, you have to first acclimatize the patient. So most likely his hands, we should test first on the hands so that he really gives the correct answer. And if he has loss of vibration sense, then he will be able to make up the difference between the two. So I will ask him and he has to say loudly if he feels vibration. If he doesn't feel, till then he doesn't comment.
Yes. Yes.
Sometimes patient can also be very clever and they can say yes when you apply. So what you do is keep your hand, do like this, but don't allow it to vibrate and keep it. If he say yes, then check him. This is giving incorrect answer. So once we have tested that he has understood what the vibration sense is, we test it on the lower limb.
Yes. Yes.
We should also test on the other side.
Yes. Yes.
Usually, as I said, neuropathy is bilateral, symmetrical. If you find only affection of right foot and sparing of the left foot, that means this is not diabetic neuropathy. We should look for some other cause. Then we can quantify this by using special instruments like biothesiometer.